Population now coming for anesthesia, never before. Is the trend more towards geriatric population?
There was a time when we looked at colorectal cancer, then it was in the younger population between 30 and 40, 60 and 70 now.
Okay. Okay, are you ready now? So the first question goes to the anesthesiologist.
Yeah, the first question is for the ma'am. Ma'am, what are the most impactful strategies to optimize common comorbidities like hypertension, diabetes, cardiac disease in elderly patients for before the surgery?
Okay, before answering, thanks to Dr. Pooja and congratulations to the AIMS team for this conference. Um, so we've had 3 talks in the morning, of which the second talk was about the perioperative management of the elderly. So when we look at the most impactful strategies, how we comprehensively look at a patient, and the care of the elderly starts from the OPD. So when they step into the OPD, I think that's the time when they should be sent to your physiotherapist, they should be sent to your physiotherapist, your nutritionist, they should come to us. They should not come back and forth for PACs. So right from the beginning, if we know what drugs they are on, are they on polymedication, can we bring down the number of unnecessarily medication and make sure that they are just on the right medication? And one of the biggest thing is that when we give them instructions, what to stop when they get stopped at the wrong time. So I think the care starts from the OPD. It should be comprehensive from the OPD, and follow-up should be there, especially for all the patients who are for elective procedures. So like it's put up on the slides, obviously when they go to a nutritionist or they go to your physiotherapist would be, stopping smoking, stopping your weight management. So if you have had a weight loss, you need to ensure that they're eating well and what exactly they're eating. Elderly patients are very, very picky on what they eat and how much they eat. So if they have to have one roti, they will eat one roti, they will not increase it. And that roti is must. They'll probably come down on their proteins, but they'll ensure that roti goes in, which is really not doing anything for them. So very simple thing, same thing. I already spoke about the management. In case for whatever comorbidities they have, you should take a formal review, whether it's their cardiologist, whether it's their nephrologist, whether it's the endocrinologist, whether it's a neurologist. You must make sure that you have them on board and you have the confidence. So I'll give a very simple example. You have an elderly who says that this medication works for them. It's just impossible for you to change their hypertensive medication because this has been suiting me for the last 20 years, irrespective of what their blood pressure is. So it's that psychological dependence on a certain medication. So you really need to work hard on them. And frailty, we had a lot of discussion on frailty. You have to know exactly. So frailty, basically you need to know at what level of frailty they're coming to you. Is it increasing, decreasing, what your disease is going to do to that patient, and what steps actually you can do to prevent it. So that is very important when we look at frailty. Is just not saying that he's frail and I'm not going to do it. Can we prevent it? Can we stop it? Can whatever we are doing, we're going to do an 8 or a 9 hour free flap on a 70-year-old. Is it really worth it? So you need to make sure that at the end of it, they do not come out absolutely delirious and they don't know where they are. So all these things have to be taken in and documented well. So I think that is where you need to look at all the comorbidities and comprehensively look after them.
So this was the question. We have summarized the answer of Dr. Lalita Gauri, which is there on your slides. That lifestyle changes, medication management, cardiac rehabilitation, and frailty. And accordingly, we can have, these are the impactful strategies. Thank you, Dr. Lalita. And now the next question is to our radiation oncologist, Dr. Kishle.
Sir, my question for you is, how can a multidisciplinary team like a tumor board help prevent delay in surgical treatment of elderly patient?
So, a multidisciplinary team, it's a tumor board or the MDT, which is like basically it would consist primarily to consist of a surgeon, a surgical, a medical, and a radiation oncologist, along with an oncopathologist. So now it has become a standard practice in most oncology centers to chalk out the evidence-based treatment for a cancer patient in an MDT, and so therefore. If an elderly patient needs surgery, then MDT definitely is going to help prevent the delay in the surgical treatment of that patient.
We have summarized the answer of Dr. Kishle that we must have a multidisciplinary tumor board, which is commonly known as MDT, and it should be a standard practice in most of the oncology standards, and it will definitely help prevent delay in the surgical treatment of a deserving elderly.
Thank you, Dr. Kisle. And now, one of my questions is for the general surgeon, Dr. Robin Kaushik. So, sir, my question to you is that in your surgical practice experience, what do you think can be the best strategy to have a better coordination among the surgeons and the anesthesiologists to prevent delay in surgery of the elderly patients? I mean, how can we better coordinate with each other so that the patients don't get cancelled?
So I'll say something which I won't repeat ever again. And that is, we have a very good department of anesthesia and our cancellation rates are probably very low.
Oh, thank you, sir. Thank you very much.
I won't repeat it again.
Oh,
I
yes.
hope it's not being recorded.
It is getting recorded, sir.
So coming to the answer, I think the most important thing is to talk to the faculty who is posted on the table that day at the very beginning and discuss whatever is needed to optimize your patient. So if I can say it in one word, it's just communication with your colleagues. And even if he asked specifically about anesthesia, but even with other specialties, if you talk to them directly, you will find that it's much easier to manage these patients or optimize them rather than letting them run around in the hospital and not finding what is, or not being aware of what is going on. And the second thing I can say is that if you have tricky patients, it's better to admit them for a few days before surgery and then sort out things in the hospital. So I think these two things would help us a lot in.
So, sir has.
So can I add something to it? It's,
Yeah,
you know,
please.
this is for all residents here. So when a PSC comes to us from the surgery department, it just says PSC. Whether you're operating on a finger or you're opening the gut, it's not written, it's just saying PSC. You know, so what is it really? What are they really planning out to do? That's
Not
the
in
first
our
thing.
hospital.
A lot of places.
और इसी के साथ सर्जन और एनेस्थेटिस्ट की लड़ाई शुरू.
Sure. Okay. And then the second thing is for the anesthetic resident. You know, when we refer them to a cardiologist or refer to a cardiologist, what for? What exactly is the cardiologist? What opinion do we want from a cardiologist, or what do we want from a nephrologist, or what do we want from an endocrinologist? Please write, this patient is planned for blah, 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 and this is the duration of surgery, this is what we're expecting, and this is how we want you to optimize the patient. So I think the anesthesia resident is equally responsible to make sure that you're exactly asking the right questions to your physicians.
Thank you, ma'am. And this is the kind of answer which Dr. Robin has given, where he has mentioned communication, communication, and more communication. One of them stands for anesthesia people also. Thank you, sir. Thanks for your answer. And now the next question goes to general physician.
So, are there any specific markers or assessments for nutritional risk in geriatric patients that can prevent last-minute cancellation?
So good morning to everybody. We've been discussing frailty since morning and it's a very important part. But as a physician, I need to objectify it. I need to be objective regarding it. So we have certain tools with which we can objectify what is the level of malnutrition in this patient and what is going to be the risk of complications in these patients. So frailty index, somebody was discussing in the morning, and similarly we have a SGA, subjective growth assessment, which we have been using. But as the name suggests, it's subjective. And even with the frailty index, you are asking questions from the patient regarding what is his functional disability. But so these are all observer dependent. So might not be reliable, might not be as valid as we would want if a patient is going into a surgery. So then we go to more objective assessments like a mini nutrition assessment. So the name is mini, but it is not mini. It is consists of almost 18 questions, which you have to ask also the patient, and you have to assess the patient. Like, what is the patient eating? Like fruits, vegetables, his diet intake, whether he has experienced any dietary changes in the past 3 months, whether he has been having any weight loss in past 3 months, is he able to do his job? Is he able to do the daily activities of daily living by himself? And then we objectively assess the patient also by measuring the BMI and taking the mid-arm upper circumference and also the calf circumference. So by all these objective measures, we can calculate a score, which if it comes, it is usually out of 30. So if it is less than 24, we might say that patient is at risk of complications, higher complications. The MNA, that is a mini nutritional assessment, is a validated tool which has shown to have increased morbidity, increased mortality almost 3 times, and also increased length of stay during hospitalization. So it's a validated tool, but yes, as I said, it is tedious. If I'm busy sitting in the busy OPD, I do not have the time to ask all those questions and do all those assessments. So it would be better suited for a patient who is hospitalized, where I have time and patient has time. Patient also is hospitalized, and I also have time to analyze and assess the patient. So what do we do if I am in the busy OPD? So there comes the third one, that is the geriatric nutritional risk assessment, GNRA. So it's a tool which is an objective tool, which is using a combination of serum albumin with the ratio of body weight of the patient to the desired or the ideal body weight. So there you need not be worried, because it's an online calculator, so you can just go online and calculate it. So there again the risk is assessed based upon whether it is less than 82. So if it is less than 82, it has been shown in studies for in fact even for COPD patients, for CKD patients on hemodialysis. So it has been shown if the score is less than 82, patient has a higher risk of going into complications. So this is the tool which is quite validated and easy to use. But again, when we are using serum albumin, we have to take care. Serum albumin has a long half-life. So if we are in hurry, you cannot use this. And acute illness also, it won't be that reliable. So there again, we have to rely on mini nutritional assessment to basically establish whether patient is malnourished and at high risk of complications. So it's not a single parameter, we have to remember. It's a combination of factors, clinical features, your examination, and then the biochemical parameters which decide whether the patient is going to land up in complications after surgery.
Thank you, Dr. Alka. So we have asked for specific markers or assessments for the nutritional risk, and this is the summary. Some are subjective global assessments, and then there are many nutritional assessments, and then we have a geriatric nutritional risk index, and she has comprehensively explained everything. Thank you. And now we move on to the next question, which is for an orthopedic surgeon. And the question is,
So, sir, in what situations, if any, should the quality of life post-surgery outweigh the risks of cancellation, especially in terminally ill, severely frail patients?
Good morning. So basically the fractures around the hip and specifically the fractured neck femur. So it is the only condition which is managed by the minimal invasive surgery, that is the bipolar hemiarthroplasty, and patient can walk in the evening on the next operative day. So this is the condition in which I would say ki the risk can be assessed. It's true that ki the patient first come to a surgeon, and we are the first one which can better explain the risk of surgery. If some 98-year patient come to me with a fractured neck femur, then of course I can tell with his relative that risk is there, but the patient can walk. So it's better to tell. We should not keep everything on the anesthetist, that they will go for a PAC, then they will risk the assess. But we should, in the terminally ill, severely frail patient, risk is there, but yes, you can get benefit from the surgery. So fractured neck femur is the condition, sir.
so this is the summary of what Dr. Saab has explained to us, that we must have a thorough discussion between the patients, relatives, and the healthcare team, and carefully weighing the potential benefits against the risks. Thank you very much. And now we move on to the cardiologist. And the question for you is,
Are there any specific interventions that can stabilize or improve the functional status of a geriatric patient before surgery?
So thank you, sir, for inviting me. And this question is very specific because I know that as the age increases, most of the time you will see calls from either the surgeon, orthopedician, or the anesthesia guys that we need to know whether we will be able to like pull him out of the surgery and the early post-operative course. So most of the time in elderly people, what bothers them and what bothers us is also important. So what all things start coming or creeping in once a person starts crossing 65, going towards 80s, and then. So first and foremost, patient chances of having an established coronary artery disease is very high. Second thing is ejection fraction going down because of a coronary artery disease is high. Third thing is left ventricle starts getting stiffer, so chances of diastolic dysfunction is high. Fourth thing is once a person starts crossing 80s, his chances of having arrhythmia abnormalities like atrial fibrillation is very, very, very high. So these are predominantly the problems with which the patient comes to us. And our issue is how can we stabilize them? So most importantly, we need to know whether they are there in them. by doing certain like evaluations in terms of getting an ECG and an echocardiography to know whether their heart function is fine. Anybody is having a heart function of less than 35% is having high probability of going into perioperative complication, because surgery will require good amount of fluid being given, and that may not be tolerated by a patient who has an ejection fraction of less than 35%. But more importantly, we need to know certain reversible factors. Are there any reversible factors? But for that, we need some time in this patient. We need a time for evaluation, maybe a week time or so. If it's an emergency surgery, probably we may not be able to support them. But if it's an elective surgery, we would require some evaluation needs to be done 1 or 2 days, and then we can fix those problems, such as optimization of medical therapy for heart failure, giving better drugs for rate control in atrial fibrillation, or trying to give him rhythm control also. And if a guideline based medical therapy is, if the patient is on 48 to 72 hours on that, his chances of having a perioperative complication and coming out of the surgical procedure is going to be high. But another important thing, as Dr. Robin has said, a better communication. If a surgeon is going to take for a surgery which is going to last 6, 7, 8 hours, going to have a huge amount of fluid fluxes in this patient, then you need to keep the patient well dehydrated and well optimized intra-procedural by giving fluids only till that point of time, and give him diuretics in the post-procedural time. So a better communication between the surgeon, anesthesiologist, so that is what is called as a heart team approach. You need to talk to anesthesiologist. Probably you may have to give a personal call to the anesthesiologist. Okay, you are going to take this patient and this patient deserves to have a surgery. Take him, give him this much amount of fluids, tell the surgeon that in case fluid is not getting managed, replace it by blood, so that there shouldn't be much of a fluid overload, and that is what we can manage. So these are the summaries, I think so. Most of them. And one more important thing, if a patient has already had a LV dysfunction and there are reversible factors, like you can put in a device like CRT or a CRTD which can improve the ejection fraction in next few days or few weeks from 30% to 40-45%. The reversible factors needs to be addressed specifically from cardiac point of view.
Thank you, dear. Thank you very much. And just watching the very keen participation of the audience, एक एक क्वेश्चन आप लोग ध्यान से सुन रहे हो. It is much better कि अब अगले 2-4 क्वेश्चन आप लोगों के लिए है. ठीक है जी. So मैं वॉलंटियर तो कर रहा हूँ कि कोई भी anesthesia, I mean any person who can answer the questions over here, and just give us few moments. हाँ जी. So these are the questions for the open house, and this is the incentive. नहीं आपके लिए रखा हुआ मैडम, उन्होंने काफी कुछ रखा हुआ है. So okay. Now the question is, what are the best approaches to manage preoperative anxiety and pain expectations in geriatric patients?
Anyone?
Anyone? Tanveer?
So for anxiety, it is a good communication and counseling.
सारा
And
कुछ
for-
communication के ऊपर ही है.
And sir, for pain, it is the on arrival blocks.
On arrival. अब थोड़ा सा इसको elaborate
So
करेंगे
like the
house के लिए.
femoral nerve blocks, the fascia iliaca blocks.
और अगर ये इलेक्टिव पेशेंट्स हैं, जैसे आपने तो ऑर्थोपेडिक्स वाली बात हो गया ना, इन जनरल कुछ
So the pain expectations for elective cases.
ये आपका कंफर्म्ड है.
So like we have to be very open to whether we need to give opioids or whether we have to depend upon NSAIDs, because the kidney function is a little on the marginal operability. So I don't think giving Voveron, one thing we should tell the residents, giving Voveron, just charting Voveron should always be red flagged, and giving too much of opioids also, you should be always aware of their post-operative sedation, any chance of respiratory compromise. So it has to be balanced depending upon the physiological status of the patient, the type of surgical intervention which is being done.
That's good. Thank you very much. Ma'am, Kanya has to add, please.
I think for elective surgery, if it is a nonagerian, so it is better to go and meet the patient. A sympathetic anesthetist who meets the patient pre-op will allay the anxiety much more, both for the patient as well as for the
The
family.
sympathetic anesthetist will bring down the sympathetic drive.
Huh? And for the
For the surgeon.
surgeon. Well, I'm not too sure about it. So one thing is that you meet the patient, explain the procedure, that what it will be done. It helps them to comprehend better, because all of us, we are scared of whatever is unknown. And regarding medication, for say geriatric patients, say we are talking about say 65 to abhi young elderly ho gaya na. So like for like the orthopedician talked about fracture neck femur and all, so they are usually about 80 years old or so. So we don't give NSAIDs to them, taking into consideration that their renal functions are deranged, and even not, so that can be done. So the talking to them and what Dr. Tanveer has said, absolutely true. While shifting the patient like from the bed, we can do it even in the like bedside also. Fascia iliaca block or a femoral nerve block will allay their pain, and that will help them to cooperate in the intraoperative period much better.
Thank you so much, ma'am.
Thank
You have
you
so
very much.
comprehensively
Right.
put it, ma'am.
Ravneet,
And ultrasound guided
please.
blocks, sir, the workshop is all about that. Genetic patients, it's going to help a lot.
So one for ma'am and one for Tanveer. Thank you very much. And कशिश बेटा आप बड़ी देर से मोबाइल पे हो, अगला क्वेश्चन आपके लिए, प्लीज रीड इट नाउ. So how should we approach the informed consent in cognitively impaired elderly patients when there is no clear-cut surrogate decision maker available to us? Kashish, please. 2 chocolates हैं. Your own experience. Kashish is in Sangrur PGI campus. Mic, please, to Kashish.
Sir, we should ask the patient family members regarding what to take, how to go for the surgery, as the patient is not able to
But
take
if we
clear,
do not have a clear surrogate decision maker available to us,
then
तब
we
क्या
should
करना
go
चाहिए?
what is best for the patient, as the patient is not in a state to take clear decisions.
This is a very in-depth question, and I want the views of other people in the house also. So please.
There should be a committee. There should be a proper way of an in-hospital committee. It should, like the way we are sitting here, 3-4 members, one from medicine, one from the surgical background, one from the anesthetic, and they should, one from the admin, and they should put forward very clearly that the risk of doing surgery, the benefit of doing surgery outweighs the risk of not doing surgery, and that should be combined inside, and that becomes a legal document, and that is how we can do this.
That's fine. So ideally, there should be a committee to decide upon that particular thing. Thank you very much. And now we again shift back to the panelists. Thank you. So the next question is again back to the anesthesiologists. And ma'am, your question is, can we minimize the impact of medication interactions that can lead to cancellations, and is de-prescribing always beneficial before the surgery?
So actually, I need to see show the slides to this thing. So if you look at the literature, there's almost a 20 to 50% non-adherence to prescription, and this leads to almost 7% cancellation of elective. This is actually in literature. And what one needs to do is when a patient comes into your OPD or comes into your emergency, you really need to document carefully what medication the patient is on. De-prescribing will help actually in a medical way. Whether it helps psychologically to the patient is another thing. They will be on a bucket full of multivitamins and a lot of stuff. When I was working in Australia, a lot of people were on milk thistle, and they would bleed the moment you put an epidural in. One doesn't even realize that what milk thistle actually does. And it's supposed to be very good for the heart and stuff like that. So these few things which are available off the counter, one needs to be very careful of what the medication the patients are on. They need to be discontinued, and they need to be very well talked to the patient when you discontinue these drugs. Less is, as I said, polypharmacy, obviously there's we need to know there's an increased risk to the adverse drug reactions that's there in literature. We need to know what medication they are on, so we know we are doing to the patient and what medication we are giving on table to the patient, and if whatever other drug interactions. Patients, there are a lot of patients on haloperidol, there are a lot of patients who are drugs for dementia. And these patients, we see them waking up on the table, we send them to the recovery, and they immediately fall asleep and start desaturating. So you should know a reverse, how after half an hour of shifting them out, how they again fall asleep. So that cycle has to be followed up very carefully. We do not have aged care providers here, but overseas you'll always know that there are nurse educators and aged care providers available. There are parents who are alone. Even it started happening in India. You have your elderly parents whose children stay overseas and they have nurses looking after them at home. So you should be very careful of what medication they are on. And this is, I'm telling you from experience, when I didn't know that my father was taking as much as 40 milligrams of of zolpidem at night, because he would take 20 and then he would wake up at night and take 20. In the morning, I would go and have find him slurring. The nurse would just say that, "Nahi, unhone manga, maine de diya." So imagine if he were to go into surgery, I wouldn't even be able to give that history. So these few little things go a very long way in how the patient is behaving on table and will behave post-operatively with you. So you have to get your pharmacist, nurse educator, if you have it in your place. So that's, I think, my crux of the story.
Thank you so much, ma'am. So the devil lies in the details. For a geriatric patient, they are on so many medicines. We need to have a detailed history, spend some time with the patient, jot down all the drugs, and jot down and come to know what drug exactly the patient is on. And these may have an interaction with the
One last
drugs.
thing, de-prescribing is not the same as withholding. So when we read, withhold a certain medication in the morning of this thing is that you've been giving it and it needs to be withheld in the morning. That's a different thing. De-prescribing is something that starts a week before.
Right, ma'am.
Thank you very much.
Thank you so much, ma'am.
भाई ये बीच में क्या आ रहा है? अच्छा उसमें नहीं आ रहा है, इधर कुछ आ रहा है. Anyway, so the next question is to radiation oncologist. Sir, radiation intervention like brachytherapy is done in OT. So do we genuinely require an optimization of the patient before taking up, or it should be taken as an emergency?
So brachytherapy, basically it's an invasive procedure where you place the radioactive sources within the tumor cavity in order to deliver much higher doses of radiation, which is technically not possible with external radiation or teletherapy. So it offers better tumor control, especially for a localized tumor. Now, all brachytherapy procedures are carried out in an OT setting, either under spinal or general anesthesia, again depending upon the site of the tumor. See, although it is a life-saving procedure, however, it should never be carried out in haste, especially in an elderly patient. And it is imperative that the patient is thoroughly evaluated by the anesthesiologist and the physician, and if need be, made fit for the procedure in order to avoid post-procedure complications. So it should never be carried out in haste.
So to summarize, sir, there is always time for optimization of these patients who undergo brachytherapy procedures. So next time if my surgeon pushes me, I will quote you. Thank you so much, sir.
Thing about brachytherapy is that, it really, the way they have to plan this thing, it's actually criminal to cancel them, because a lot of the planning and the number of patients on their table, it's very, very tight. So just make sure that when they are posted, they are well evaluated so that they do not really get cancelled.
Because sometimes for cancer cervix, where brachytherapy is being done most often, sometimes we have 3 to 4 patients lined up. So yeah, and it has to be carried out within a stipulated time. If you delay it, then the control rates are also affected. But with the elderly population, because the patient is not fit the procedure, I mean, you cannot. That's the other thing.
I think, ma'am, it's always about outweighing the risk versus benefit. So we can always discuss and communicate with the radiotherapy colleague that whether we can wait for 3-4 days and not canceling it. But if the patient needs optimization, then maybe for 3-4 days we can delay the
All our patients go through the PSC,
Right.
a proper OPD PSC before they come.
Right.
Pardon, sir? Absolutely right. Thank you very much. And now the next question is to the general surgeon. Sir, are there any specific lab tests of preoperative markers that are more predictive of surgical readiness in elderly patients? And if they are there, then how can we standardize these?
So there are various scales that are available in literature, but frankly, we have not used them. For us, the surgical readiness is once the patient walks into the OPD, whether the patient is independently, whether needs support, wheelchair bound, or on a trolley. So from there, the assessment starts. And then, of course, there are various lab investigations that we like to see, which is hemoglobin, blood sugar, creatinine, and albumin. These four are very important as far as I am concerned. And then, of course, you ask your colleagues to have a look at any problems that might be there. We did a study on frailty a few years back, so that has shown us a good correlation with post-operative complications. But as far as surgical readiness goes, we didn't look into that. And last, what can be done very easily in the OPD is the timed up and go test. So you just ask the patient to sit on a chair, walk across about 2 or 3 meters and 2 or 3 feet, and then come back, and you see how much time the patient has taken. And that gives you an idea of the physical or physiological reserve of this patient. So I think these are the easier things that can be done in the hospital.
Thank you so much, sir. Very nicely put. Tongue test is very easy test to do. If the patient takes more than 30 seconds to go and come back, possibly the patient is like not very fit. So that patient can be further evaluated. Next question is for.
So the next is for Dr. Alka. Your question is that what are the best practices for managing the polypharmacy in elderly patients, and how can the medication adjustments be streamlined preoperatively?
So the question has rightly come to me because we are the culprits most often. Being physicians, we've been writing plethora of medicines for all the patients, elderly patients especially, but they have comorbidities. So what we need to see is, as ma'am rightly said, de-prescription. So she briefly touched upon why do we need to de-prescribe. First, we need to see whether the patient really needs that medicine. It's an unnecessary medicine, so we can cut it out. Secondly, are there any interactions, medicine to medicine interactions? Are they interacting and giving a patient side effect? Are the side effects outweighing the benefits? So we need to cut that medicine also. So we can do only if we are reviewing the patient. क्योंकि हमारे पास कितनी बार आता है पेशेंट दवाई लिखवा के लेता है and then lost to follow up. So we need to emphasize that patient needs to come back to us even if he's asymptomatic. At least once in a year, review of medication is imperative, so that we know that patient really needs those medicines or not. So review once a year, and every time the patient is coming to the hospital or hospitalization is being done, because the regular practice is PGs जो चल रहा है पहले वही चला दिया, कहीं से दवाई चल रहा है, कार्डियोलॉजी की दवाई चल रहा है, वो रिपीट कर दिया. We need to see whether exactly those medicines dosage adjustment is needed or not. So we have to review this patient every time he's hospitalized or lands up with us in emergency department. Secondly, this prescribing has its own barriers. So patient barriers, as ma'am said, कि मैं तो ठीक चल रहा हूँ, मैं क्यों कम करूँ अपनी दवाइयाँ. So this is one of the patient barriers कि अगर तुमने दवाई कम कर दी तो मुझे क्या होगा, मुझे प्रॉब्लम होगा. अनसर्टेनिटी कि अगर ये दवाई बंद हो गई तो मैं ठीक रहूंगा या नहीं रहूंगा. Then comes the physician barrier, inertia. Patient ठीक चल रहा है, मैं क्यों दवाई टच करूं, सब कुछ चल रहा है, चलने दो. So that is a barrier from our level. So we need to come out of our inertia कि नहीं, पेशेंट को चाहिए ही नहीं इतनी दवाइयाँ. Then third thing is कि पेशेंट मेरे पास आया, डायबिटिक हाइपरटेंसिव है, मैंने दवाई लिख दी. Then he says कि मुझे तो कोलिलिथाइसिस आया, मैंने सर के पास भेज दिया, सर ने अपना दवाई प्रिस्क्राइब कर दिया. फिर उसने कहा मुझे राइट नी पेन है, ऑर्थोपेडिशियन डॉक्टर अमित के पास भेज दिया, सर ने अपनी दवाई लिख दिया. फिर उसे कुछ चेस्ट पेन निकल आया, फिर कार्डियोलॉजिस्ट के पास चला गया. अब लेकिन हमारे पास बिजी ओपीडीज में हमारे पास इतना टाइम नहीं है कि उस डॉक्टर ने क्या देखा तो मैं क्या डुप्लीकेशन तो नहीं हो रही, रेपिटेशन तो नहीं हो रही. सो व्हाट इज पेशेंट पूरी थैली भर के हमारे पास दवाई लेके आता है, मैं तो ये ले रहा हूँ. So do I have the time in the OPD to see this patient? But if elderly patient is there and patient need to be taken up for surgery, we need to. And even if it is not to be surgery, if it is not even undergoing surgery, if the patient is coming to us and with comorbidities, we need to review his medicines, even with whether we have time or not. So this has to be done, and there is a beautiful tool online, comprehensive geriatric assessment, start and stop. So stop is where you have to review the old people prescriptions regularly and need to cut out the medicines which are not required. And start is when to start the treatment in these patients. So it is a beautiful document which is giving us system wise, which has covered every system. So you can go to that document and review. So what medicine really patient needs? क्या उसको इतना multivitamin खाना है जो मैंने भी prescribe कर दिया, डॉक्टर अमित ने भी कर दिया, सब लोगों ने, तो he is using multiple multivitamins, multiple antihypertensives, multiple treatment which is not required. So that basically we need to review the patient regularly. And communication, yes, but nobody can emphasize more. Communication is the key. So it has to be a shared decision making. ये नहीं कि मैंने अपने लेवल पे नहीं, तुम्हारा तो बीपी ठीक चल रहा है, मैंने एक अपनी एंटीहाइपरटेंसिव अपने लेवल पे काट दी और पेशेंट को बताया नहीं, पेशेंट ले ही जा रहा है, या फिर उसको बताना पड़ेगा कि नहीं आपको जरूरत ही नहीं है, उसको लगेगा कि मेरा तो बीपी कम हो जाएगा. So a shared decision making with the patient is most important.
Thank you, Alka. The answer is full of emotions. भाई कभी ना कभी तंग किया है फिजिशियन को हम लोगों ने. We're very sorry for that. Anyhow, I mean, she has summarized in 3 headings like working as in a team and then de-prescribing and then enhancing the health team outcomes. Thank you, Alka. And now the next question goes to Dr. Amit, orthopedic surgeon. And your question is what protocols can be implemented to safely manage blood thinners or antihypertensive medications to avoid last minute cancellations?
Now, Dr. Alka will more frustrate on this question because as the first X-ray has come to us, so what the thing we see on the X-ray, the first thing that come in the mind is when to operate this patient. Second thing come in the mind, how to operate this patient, which implant you will use, which osteotomy, and we forget that the patient was taking which medication. He was taking any blood thinner or not. So in the end, it's the history taken by the surgeon is very important, and after taking this, a good communication with the physician, because basically if the patient is on some anticoagulants, then we have to see how much is the risk of bleeding during surgery if we don't stop the anticoagulants, and how much is the risk of clotting if we stop the anticoagulants. So I think the bridge therapy we should discuss with the physician. I know madam is very busy in the OPD, but we have to discuss this thing, and this is a thing, a good communication, as sir is my teacher from the GMCS 32, and sir as well said communication is the key. So a good communication between the physician which prescribe the medication, and then a discussion between to need key patient required a bridge therapy. Basically bridge therapy is a thing which say anesthetist and cardiologist can tell better, but bridge therapy is that when we stop some anticoagulant, then we supplement it with some weak anticoagulant which start 3 days and give it continue for some more days. So this is the thing I think sir we should prescribe.
Thank you, sir. Very well summarized. So communication again is the key between the surgeon, between the anesthetist, and between the physician who's looking after the coagulation treatment. So that becomes a key, I think, of this panel discussion as well, that communication should be very well sought after.
And on a lighter tone, Amit said कि surgeon should take the history. हमें तो लगता है surgeon को सिर्फ हड्डी वाले को हड्डी नजर आ रही है और इनको appendix नजर आ रहा होता है, तो ये जो physician है वाकई frustrated होता है भाई.
Sir, madam said one very good thing. Dr. Lalita said, ma'am said कि last minute cancellation is criminal. So this is a message for
बिल्कुल ठीक
it
कह रहे
should
हो.
not be cancelled at the
नहीं
last
मेरे को तो ये है कि भाई history ले रहे हो और कमाल है यार. It's really good.
सर हम GMCS 32 के ग्रेजुएट्स हैं सर. सर ने तो हमारी बड़ी क्लास ली हुई है सर हिस्ट्री.
ये हमारी भी क्लास लेते हैं यार अभी. Thank you very much. This was on a lighter note, and now moving on to you. Dear, what tools are most effective in identifying the high-risk geriatric patients who may require additional optimization prior to surgery?
So, see, we are using still the RCRS score, and RCRS score will tell you in particular numbers that if a score is 0, you have 3.9% risk, 1, you have more than 5% risk, 2, you have more than 10% risk, you have 3, you have more than 15% risk. So these numbers, how do they matter to you? This is, practically doesn't matter to a surgeon, because surgeon, if he has complication, then it's 100%. So, but that will tell you grossly that the patient is having high chances of having complication. Then what are the risk factors out of the 6 parameters which are taken in RCRI? If the patient is having 3 parameters which are deranged, then he may need to go to a particular specialist like cardiologist. Majority of the time the cardiologist will be able to give answers to those or will be able to optimize that. But the most important thing again lies in cardiology evaluation is to identify reversible risk factors, like if the patient is having a heart failure, whether we can optimize with medications. If the patient is having atrial fibrillation, whether we can optimize his heart rate and give anticoagulation. If he is having angina, whether we can address the angina by medication or we need to do something more like angioplasty, which can further delay the surgery. If it's an urgent surgery or emergency surgery, we can't do that. But if it's an elective surgery, can be delayed for 3 months or something, we can still do the angioplasty. So the most important stepwise approach for identifying is RCRS score. RCRS score moderate and high deal with those two parameters or three parameters which are deranged by optimizing the medications, by giving certain more therapies to optimize the heart failure or angina, and then if the patient is stable enough, then send to a surgeon, talk to the surgeon once again whether he is happy to take this patient on single antiplatelet therapy or a dual antiplatelet therapy. I'm answering his question also. If they are okay with single antiplatelet therapy, let them continue, because the risk of stent thrombosis is like taking away the life of the patient. And if the patient cannot be taken up, then bridge to a Clexane or a low molecular weight heparin and take the patient for surgery.
Can I ask a cardiology question?
I just wanted to ask, nothing to do with coagulation or anything. So one thing I very strongly believe, could correct me, is that we give these tablets which have 3 drugs in it. It'll have a diuretic, it'll have a beta blocker, it'll have a calcium channel blocker. Do we really need to give them a single tablet, or should the elderly be given, if we he needs a beta blocker, when we give them separately, we can at least titrate it. Because what happens, especially those patients who come nowadays, as we call this day care, they come in the morning of the procedure, they would probably take an amlodipine in the morning, completely skip their beta blocker. So I very strongly, for our patients, feel that they should get separate, the tablet should be separate, so you can stop or increase or decrease a certain medication. So vis-a-vis, a drug which has all 3 and there's just no way you can titrate it.
If allowed, I'll take one minute. She has raised a very important and a very pertinent question. It's like polypills in elderly. Polypills is basically a drug which has combination of 2-3 drugs, a tablet which has combination like Telma AMH, Telmisartan, amlodipine, hydrochlorothiazide. So the point is, now 3 drugs are given in a fixed dose combination, and if the patient clinical status does not allow that these can be given in a fixed drug combination, you need to optimize, especially in elderly where all the reserves of the body are limited, and even a small subtle increase in the drug, which has happened with my patient. Patient was supposed to have hypertension, was on the same drug which I named it, and he took it twice because the blood pressure was high, and he was not knowing that, okay, the first 2 drugs are fine for blood pressure to be controlled, but the third drug was going to cause a severe hyponatremia. With 2 doses, patient's sodium went down to 111. So I completely agree with ma'am that in elderly patient, you need to know the reserve of the patient, and the patient is not appropriately being managed with fixed dose combination. The target of fixed dose is to reduce the pill load. If the pill load is very important for the patient, go for a fixed dose combination. But if pill load is not a problem with the patient, talk to the patient if he's happy to take individual drugs, because in international standards, there is nothing called as a fixed dose. They are all Indian standard to decrease the pill load. So they give individual drugs in the least to maximum dose dosage, and they will optimize based on single drug, which is very important in elderly because their reserve of the body is less.
Well, thank you, Parag. Now the question is to 3 people whom I am going to name. Harsimran, इस तरह भाई तेरा ही नाम है अब. Dr. Richa and Dr. Suman. Suman? अगला क्वेश्चन आप लोगों के लिए है, 3 लोगों के लिए. आई जस्ट नीड द व्यूज ऑफ दीज 3 पीपल. चॉकलेट सबको दे रहे हैं मैडम, चॉकलेट इतने ज्यादा पड़े हुए हैं यहाँ पर. Okay, the question to Suman, Richa and Harsimran is, what are the key components of a standardized preoperative? No, I think we have done this. What are the key components of a standardized preoperative checklist specifically tailored for elderly patients, and how it can reduce cancellations? So please give the mic to the audience speakers over there. सबका अपना अपना view. Here the answers will not be displayed onto the screen, and we just need the individual opinions regarding this question. So who is speaking first? Dr. Richa is speaking first. Okay, please.
So I think when we talk about a standardized preoperative checklist, one of the, as it has been discussed previously also, one of the system that needs, concern, system of concern is the cardiovascular system. So that has to be a standardized preoperative checklist. It should be included. The cardiovascular system should be evaluated preoperatively in all the elderly patients, especially as we said, more than 75 or 80 years of age. The other thing is frailty index, I think, is one, because we have already, we not only want to see the preoperative optimization, we want to focus on the perioperative mortality and morbidity of the patient as well. So the preoperative frailty index should be included. I think we are doing frailty as it is, so it can be included as a standardized preoperative checklist. And yes, thank you. Thank you, sir.
So moving on,
We are
again we
we
have
are
to
noting down
see
the names.
what are the comorbidities, what are the medications patient is on, and what are the doses of that, and what are the timings of drugs the patient is on. Again, in this age group, chances of delirium because of pain in the pre-op is very common. Hyponatremia is very common in this group of patients. So we have to take into consideration every aspect. It's not only the comorbidities, but also the social requirement of these patients, whether they are having their kins along with them or not, whether they can be taken care of post-operatively properly or not. So each and everything we have to take into consideration while planning their surgery. So, and for, next, we want to make sure that they should be operated as early as possible. So if we do that optimization in a shorter period of time, that is good for them, because it not only decreases the incidence of problem in the intraoperative, also post-operative period also, like delirium.
So these
So
are the
we
few
want
points.
early surgery in this group of
Should be as
patients.
a standardized preoperative checklist.
Yeah.
Yes, sir. For standardized preoperative checklist, probably we need to go system-wise. So every system need to be assessed, starting from above. Brain, cognitive function need to be assessed. As ma'am was already said, cardiac polypharmacy, patients on polypharmacy. Like sir also said that the patient will be on one medication containing 3 salts. So probably on the day of surgery will not require all the 3 medications. So it has to be tailor-made preoperatively. So you cannot just blindly give chlorothiazide, so electrolytes will go for a toss. So assessment of electrolytes, most important is electrolytes also, because these patients are on multiple medications. So hyponatremia is very common, hyper or hypokalemia, both can occur. So this is one of the important aspects, along with the management of diabetes and hypertension. So diabetes now, SGLT2 inhibitors are, most of the patients are on dapagliflozin or empagliflozin. So stopping them 24 to 48 hours or 48 hours prior to surgery is of paramount importance. So taking care of entire medications and documenting at what time it should be given probably is the most important for me.
Sir, I
Thanks,
think
Swati, please.
what we have discussed already, the model of
Mic to
comprehensive
Swati, please.
geriatric assessment, that
नहीं नहीं आप अपना कंटिन्यू करिए. Swati has to contribute, please. Chocolate for Swati also.
Sir, I just want to summarize that a protocolized approach. In every hospital, elderly patients come. So we have to journalize that whether it is an emergency surgery or they are planning for an elective surgery. If emergency surgery is there, we have to just optimize or get a cardiology evaluation or just see what the lab parameters are there. Like for hip surgery only, we know that if hip surgery is taken at the earliest, the pain will be settled, the risk of delirium and the risk of post-operative pulmonary complications will also be less, and the less DVT chances, less blood loss is there. Everybody will be more comfortable. So we have to get a protocolized approach, elective or emergency surgery. If emergency surgery, we have to, fast track the things. And in elective surgery, we have to system-wise optimize everything and but the elderly patients need to be done at the earliest.
Thank you very much. And may we have the last question for
No,
Ritu, Ravneet, and Dr. Pooja?
So just one thing I just want was I think completely been missed in the whole thing is one, we have to have a high index of suspicion for UTI or maybe some form of lung infection in this subset of patients, the elderly, who especially if they are bedridden, all patients who have had fracture neck femur have been on lying down on bed, and it's just not about everything is about DVT. one has to be very, so if, you must be looking at the TLC counts. If you think that they're running fever, just all these little things. So high index of suspicion for this small thing.
One more thing I think which we usually miss is the preoperative cognitive dysfunction in elderlies. So these days, I think as we are also growing, so standardized preoperative checklist in the coming days, there are so many serum biomarkers, simple biomarkers, which are associated with increased postoperative delirium in the postoperative. So who knows that as the time goes by, one or the other markers are included, they can be included for preoperative screening of postoperative delirium.
Thank you very much. And now the next question is to Dr. Pooja, Rajni, and Ritu. Yeah, please, ma'am.
Preoperative delirium, if we happen to see, we must always see the correctable causes and treat them accordingly, because as Dr. Gauri mentioned, UTI is one of the commonest cause for delirium in these elderly patients. So that should be taken into consideration. So age only do not contribute to delirium.
Thanks for your input. Also, this last question is to the hosts only. Pooja, Ravneet, Ritu, and Ananya is here. Since this is an upcoming institution, so can we have some kind of specific institutional policies for the care of elderly?
Sir, this is a very good question actually, because it needs to be implemented. Sir, as the surgeon said, like when to operate and when not to operate is a big decision, and also we should have when to intervene and when not to intervene, because now end of life care is very important. Sometimes we just need to not probe and prod the patient again and again, and just make the end of life care as easy and as comfortable as possible. The palliative care should be optimized for the patient. So we need to have an institutional policy, and the residents should also be involved in that from their post graduation itself. As a PG resident, we never had the concept of palliative care. We are learning now, but if it's instilled in the growing years of their residency, it will be definitely helpful for the patients as well as for your own satisfaction also. You have done the best efforts, and sometimes the best efforts are just to hold the hand and provide empathy to the patient and the family itself.
Pooja, Ananya, Ritu, 4 chocolate है, देख लो किसको ली.
चॉकलेट के लिए कुछ भी सर.
2 तेरे लिए.
So apart from institutional policies, like we can have a committee, that we have a protocol, that we have an elderly patient for surgery, so we make a fixed protocol so that these things, checklists are not anybody, even if the first year sees or the consultant sees, we follow those checklists so that we don't miss out on anything that can definitely help out, even if the person has little knowledge. But if it is a protocolized thing, it will not be missed.
Thank you very much. Thanks a lot. And
So we have some.
Ananya has.
So can I just say something, please, before,
Yep.
sorry? So we have something called as a joint clinic, where we have the medical oncologist, the surgical oncologist, the pathologist, the radiology people, and all high-risk patients in our institute go to a high-risk JC. And it is just not my decision, it's the surgeon's decisions, it's everybody's decisions, everything is discussed. And then the relatives and the patient are called in and explain the risk of the surgery or anesthesia to them. And it is basically letting them know what are the pros and cons of going in for this surgery and what is the general outcome. So our high-risk cases go through a high-risk JC.
Absolutely, very good policy. Ananya,
So I came from an institution where I never had to think about anything, and whatever we asked for, everything was done. And I came here, so I realized the challenges that we have faced over here. So I feel that yes, definitely it should be an institutional policy, seeing the setup of the present place where you're working and where you can suddenly have a challenge. And in this institution, for example, now post-operatively,
limited resources. As a
very limited resources. We don't have people, we don't have interventions. So once you've taken a patient, it's not like you can kuch bhi kar diya and kisi aur pe saunp diya.
Ananya,
So that's not
तुमको
right.
इसलिए यहाँ रखा. You should be here for this. You have to bring up this institution.
So definitely institutional policy is very important, and that should be a collective effort from all the stakeholders.
With that, we conclude the panel, and thank you, Dr. Lalita, Parag, Amit, Alka, Dr. Robin, Ishle, and my dynamic co-moderator, Vikas. Thank you, Pooja, and your team. Thanks a lot. Thank you very much. Dr. Kadal.
Just one more point. When you are framing your institutional policy, it would be a very good idea to have your own cases discussed, and that's called debriefing. So if you debrief yourself on what went right and what went wrong, it will help in framing the policies further, because you can't have everything in every setup. So when we also started, we also took some initial steps, and as you overcome those obstacles, then you can see even further ahead. Correct? And so you include debriefs in your protocols.
A heartfelt thank you to the moderator and panelists for inspiring scientific excellence and addressing thought-provoking questions in our practice. I request Dr. Pooja to felicitate Dr. Sanjeev Parta and Dr. Vikas Saini.
Panelist, chocolate लिए जरा मत जाना यार, पराग को पहले इधर ही आ जाए. Oh, Pooja, it's always a pleasure. Thank you. यार तो फोटो ले लो यार. Thank you very much. Saturday को ऐसी चीज मिलनी ना, वो कुछ शाम वाली फीलिंग आ जाती है. Thanks a lot. Shape of the video.
I request Dr. Ritu to felicitate Dr. Lalita, Dr. Parag, and Dr. Amit. I request Dr. Ashwini to felicitate Dr. Alka, Dr. Kisle, and Dr. Robin. I request Dr. Ananya to kindly felicitate them. I request Dr. Ananya to kindly felicitate Dr. Amit.
Thank you, esteemed guest. Well, that was one very good panel discussion. So, for our next session, please join me in welcoming our esteemed chairpersons, Dr. Sukanya Mitra, Professor, Department of Anesthesia at GMCH Chandigarh, Dr. Sapna Bansal, Professor and Head of Department of Anesthesia, Maulana Medical College, Ambala, and Dr. Vikas Saini, Professor, Department of Anesthesia, PGI Chandigarh, whose passion and expertise are sure to leave an indelible mark on our conference. They will be chairing the session, Waking Up to Progress, the newer nerve blocks. Please welcome them with a round of applause.
Very good morning, everybody. Um, it's my proud privilege to introduce Dr. Tanvi Samra. She's an A speaker and she's going to talk about the newer regional anesthesia techniques. So, Dr. Tanvi, without much delay, since we are already running late, I think you should start off with your talk.
Yeah, so good morning, everybody. So I'll be a little quick and thank you so much for the kind words, ma'am. So I have a very interesting topic that is the newer nerve blocks. Now, if it's a very broad heading, the newer nerve blocks, every day is a new day with a new block. You put a needle in another direction, it becomes a new block. You scan it in another orientation, it becomes a new block. So to make things simpler and to give you a thorough knowledge of whatever I want to speak during the entire lecture which we have followed by the workshop in the afternoon, I have taken the liberty of just being limited to the lower limb blocks. So as you all know that you are familiar with the femoral nerve blocks, the fascia iliaca blocks, the popliteal sciatic and the saphenous nerve blocks. The residents are doing innumerable theses on these. But there are certain blocks which are untouched, especially at the residency level, and those are the adductor canal, the Peng block, IPAC, parasacral sciatic nerve block. Now, the reason why I've kept the adductor canal at the topmost is that although everybody claims that they are doing the adductor canal block and they know everything about the adductor canal block, but this is one of the blocks, which needs to be taught and learnt day in and day out because there's lots and lots to it rather than a simple adductor canal block. So it's generally used for analgesia for knee surgeries, and whenever there is anesthesia required for the lower leg, the ankle, and the foot, some people call it the adductor canal block, some call it at the subsartorial block. Now, is it same? Is it same? If you talk about the subsartorial, you are somewhere right because the roof is being formed by the sartorius, so it is a subsartorial block. And I'm not going to go into the anatomical details of the boundary, like it has the adductor longus, it has the vastus medialis. This all we'll do at the workstations in the afternoon. But one thing which you need to be really new in this is that you always talk about the roof. You never talk about the VAM, right? So what is the VAM and how the adductor canal block has evolved and what is the significance for us for the vasoadductor membrane? Now, actually, if you see the middle picture, you will find that there is a membrane which actually separates a subsartorial plexus from two different nerves, that is the saphenous nerve and the nerve to vastus medialis. Now, whenever you take a viva of a resident or you ask, what are you blocking in the adductor canal block? They say the saphenous nerve. But it is not just the saphenous nerve. Adductor canal blocks are way more than the saphenous nerve blocks. The relevance of knowing that you are causing blockage of the subsartorial plexus, you are causing blockage of the saphenous nerve, you are causing blockage also of the nerve to vastus medialis is when you go into an in-depth study of how the knee joint is innervative. Because if you just say that the saphenous nerve is blocked, then the patient should not have any pain relief if you're giving an adductor canal block. Again, I've just shown a schematic diagram. I'm not going to go into the details of the knee joint innervation. So as I told you, it is the subsartorial plexus and numerous other nerves which are being blocked. The relevance of the innervation of the knee joint and your knowledge of the innervation is very important. So I think I can give you this as a homework. Go back home, just read about the various plexus which need to be blocked for an effective pain relief after a TKR. So coming to the sono anatomy is that, again, whenever the residents are asked, this is what they scan, and they show that, we've seen the sartorius muscle, we have seen the artery, we can mark the vastus medialis on the lateral side, we can recognize the adductor longus and the magnus on the medial side, and the hyperechoic structure which we are seeing is the saphenous nerve. But is this what we need to identify? I think no. We should grow a little further and we should learn to identify both the saphenous nerve and the nerve to vastus medialis. And similarly, either you're giving a single shot block or you're putting a catheter, it is very important to ensure that it is both your saphenous nerve and both your nerve to vastus medialis which is being blocked. So if you can, it's just a video, I'll be just skipping this. We can have a detailed view in the workstations later, is that you can see the needle is approaching. So you have to be very well versed in keeping your area of interest in the middle, identifying the nerve, identifying and giving the local anesthetic in between both the saphenous and the nerve to the vastus medialis. So we have talked about the adductor canal block. Now, or which you call as a subsartorial block. So we go a step ahead. What is the dual subsartorial block? So this is a step further. Now, as you can see in the figure, you see that you can see the adductor longus and the sartorius, they're just crossing each other. So the anatomical boundaries of the femoral triangle and the adductor canal can be easily delineated. So why do we talk of a dual subsartorial block? The image shows the different areas which are being blocked and the analgesic coverage which is being given by all of them. So you can see in the third figure that if I give a dual subsartorial block, then only I'm going to have an effective pain relief, because it is generally on the medial side that the incisions are given and the most of the operative procedures for the TKR is being done from the medial side of the knee. So what do I mean by dual subsartorial block? A dual subsartorial block consists of a distal FTB block, that is a femoral triangle block, and a proximal adductor canal block. So that is a dual block. So when you are giving a distal femoral triangle block, so you are actually, you see the first image over there is the nerve spread goes to the prepatellar plexus, and the local anesthetic is mainly going to act on the lateral femoral cutaneous nerve, the nerve to vastus medialis, and all the adjoining nerves which are there in the peripatellar plexus. But when you come down 2 centimeters down and you give a proximal adductor canal block also, it is your infrapatellar branches also and your popliteal plexus which is additionally being blocked. So we have now learned that we have an adductor canal block, we have a, which is also called as a subsartorial block, we have a dual subsartorial block which is a combination of some amount of drug which is given in the femoral triangle and then scanning, coming 2 centimeters below and giving a proximal adductor canal block. But how do I know that on ultrasound what is the femoral triangle and what is the adductor canal? So again, in the workstation, I will be telling you how to identify the figure of 3. The figure of 3 is when you see the sartorius and the adductor longus, right? Do we have a pointer? Okay. So if you can see this, right? So it's you can see the sartorius and the adductor longus. When they meet, they form the figure of 3. So where you form the figure of 3 is actually the apex of the triangle. Again, I'll show you more in the workstation in the evening. So after this, we come to the third new kind of block, which is called the IPAC. So it's actually full form is the interspace between the popliteal artery and the capsule of the knee joint, right? So this is very much in, and if again you see the analgesic cover which is given by different, you will see that the IPAC block additionally is going to cover what is being left by your subsartorial blocks and what is being left by your adductor canal blocks. So this is just because these are those refined forms of blocks, you just need to have a knowledge, right? You may not be proficient, so don't worry about it, but just a little bit of knowledge that what you give. So you give it in the interspace between the popliteal artery, and 20 ml of 0.2% ropivacaine is given. You go advance your needle posterior to the femoral shaft, right? And you give in a posterior lateral direction. This is how you place the patient. This is how you place your probe. You can see the needle entering. And what you are aiming at is you are aiming at blocking the popliteal plexus. Now we go a step further. So what we can do is we combine the IPAC with an adductor canal block, right? So there are different combinations which can be used, because no single technique of block is going to make the patient entirely pain free. So as I said, you every day you get a new block, you get a new insight of what you can do better. First we were taught about single blocks, now we've been taught about how you can combine blocks. And the main advantage of all these blocks which we are talking about, the adductor canal block, the IPAC block, all these, is their motor sparing peripheral nerve blocks. You know, since morning we've been taught about the fact that we want early ambulation in the geriatric population. So how do we have an early ambulation? So that's why we've moved away from the femoral nerve blocks, we've moved a little away from the fascia iliaca blocks, because we now want to focus on the motor sparing peripheral nerve blocks. And till now, whatever I've told you are some of the newer advances into these. The fourth thing which we generally talk about is the PENG block, right? So it's a pericapsular nerve group block, right? So it is to reduce pain after hip surgery and hip fractures. So till now we were talking about knee pain, knee surgery. So now we come to the hip surgery, the hip fractures, right? It's actually a fascial plane block, right? And the local anesthetic is injected between the psoas tendon and the ilium. So what is the aim of the block? So if you see the innervation of the capsule, especially the anterior capsule which is surrounding the hip joint, you see that it is the femoral nerve, it's the accessory obturator nerve and the obturator nerve, which if you block these three nerves, you're actually covering all your pain which is going to arise when you know cut the anterior capsule. So you are aiming to block the articular branches of the femoral, the obturator, the accessory obturator, and that all these are giving sensory innervation to the anterior capsule. So this is what you're doing. What you're doing in a femoral nerve block is you are aiming here. So what you're doing in this PENG block, you are giving a fascial block. Iliopectineal line is there, and you have to visualize, and after an ultrasonic visualization of the iliopectineal line, the iliacus muscle, the source, you just have to introduce your needle and give a volume block, and you can see that the articular branches of the femoral nerve, the accessory obturator, all are lying in this. It's a volume block. It's the local anesthetic is going to spread and it's going to give a very good pain relief. This is quite an easy block, right? So this is again the ultrasound picture. You can see the femoral artery, the femoral nerve, the psoas tendon, and this is the area, the iliopectineal, eminence, the iliopectineal eminence, which you can even feel it when you put the needle inside the bony prominence, and then you withdraw and you spread the local anesthetic. So there have been lots of studies, and people have compared the PENG, the CFI, because if you see the suprainguinal fascia iliaca blocks, then you will say, okay, there also what I'm doing is I'm giving it somewhere in this region. Your scanning area is also the same, but the difference is that it is a volume block, that is an intramuscular block, the CFI. Again, in the workstations, we will be talking about the suprainguinal fascia iliaca blocks, how they are given, how you visualize them, right? And what are the target nerves for each of these blocks. Now, one femoral nerve block is not a new block, but there is one very important thing which I want to discuss with you is that lots of residents, they do not recognize or make mistakes in identifying the femoral nerve because of the property of anisotropy. So it is very good practice to always, toggle your ultrasound probe till you're very sure of seeing the nerve. And as you know that there are lots of arterial vessels like the circumflex, etc., which may be near the femoral nerve. So again, you have to avoid all these. All this we will be doing in the workstation in the afternoon. Now, in the sciatic nerve block, all of you do the popliteal sciatics. You are very well versed with it. You know the sensory innervation, but there are three important techniques where you are generally lacking or where we are not proficient on. One is the parasacral, the transgluteal, and the infragluteal. So, the scanning technique is basically for parasacral. You are aiming to block the nerve when it comes out of the greater sciatic foramina. If by mistake you are going up, then it is the ala of the ilium which is being seen, and you can see the subsequent ultrasound image which is being formed. So always try and scan it down so that you can see the greater sciatic foramina and you can block the sciatic nerve at this point. So this shows the transducer position, the orientation. Again, subgluteal sciatic nerve blocks, I think still residents are practicing. You have to just identify the greater trochanter and the ischial tuberosity. Again, this is the picture. You can see the sciatic nerve. So how does it look like? It looks like this, hangs from the gluteal fascia. So it's just like a hammock. Again, this is your position, your transducer position. So these are all the nerves of the lower limb. Popliteal sciatic, everybody knows, so I'm not going into the details. I will be discussing in the workstation in the afternoon how you do it. But one very important point which you should know is how to identify the vein, because that is the structure you miss as residents, because you just put too much of pressure and it becomes compressible. And you must again know how to manage anisotropy when you are doing the popliteal sciatic. So one very important thing you will ask me is that, ma'am, why are you telling us about the subgluteal or the parasacral? Because I want to tell you that a large volume of local anesthetic is needed when you need to block it at the popliteal level compared with the proximal subgluteal level. There is a reason for that, because the ratio of the neural and the non-neural tissue ratio, that determines how much amount of local anesthetic has to be given and how fast your onset of block is going to be. So always try and move a little higher up and start giving the parasacral sciatic nerve blocks. Any questions? Thank you so much.
Dr. Tanvir, that was an excellent lecture. It had a lot of practical tips and pearls, and I'm sure you're going to show them and also buttress on them in the afternoon in the your session workshop. I would request if there are any questions from the house. Dr. Tanvir is very experienced in all these blocks.
I think the workshop is going to be there. Maybe they'll be asking the questions to workstation.
Just one input. Dr. Tanvir has talked about the lower extremity blocks. IPAC, it has become very popular nowadays, but practically, like, you know, when you go through the videos in the YouTube, they look very easy, but instituting IPAC block requires a very sharp angulation of the needle to put it in the space between the popliteal artery and the posterior popliteal plexus of the nerve at the back of the femur. So technically quite difficult, and I'm sure Dr. Tanvir is going to show you. Another thing is that there are many newer blocks that are coming. One such technique for the upper extremity block, the brachial plexus block, which is commonly done, that is, a new technique has come out, that is intra-cluster block. Like the drug is deposited in between the clusters of the brachial plexus in the supraclavicular fossa, and also another is the intertruncal block. So these techniques, they say that it is quite early, the block institutes quite early, and the success rate is also quite high. So once again, I invite questions. She has underscored such practical points. Any residents has any doubts, you can clear it right now. Or yeah, do you want to say something? You can put in. Do you want to? No questions. So since we are running, lack of time and everybody's waiting for the hands-on workshop. So I think I'll close the session and thank you very much for your attendance. Thanks a lot, organizers, for giving me this opportunity to attend this August gathering. Thank you very much.
Thank you, Chairperson and Speaker, for your insightful and impactful contribution that enriched our conference experience. I invite Dr. Bharti to felicitate Dr. Sukanya Mitra and Dr. Sapna Bansal. I invite Dr. Ravneet to felicitate Dr. Tanveer.
Allow me to introduce the next brilliant chairperson, Dr. Kajal Jain, Professor, Department of Anesthesia, PG IMER, Dr. Swati, Associate Professor, GMCH, and Dr. Suman Arora, Professor from Department of Anesthesia, PGI, Chandigarh, whose profound insights are about to enrich our conference with experience. They will be chairing the pro and con debate, the battle of the ages, general anesthesia versus regional anesthesia for high risk geriatric cases. Please welcome them with a round of applause.
So, debates are a good way to generate, conversation and to know what actually we should be doing. So we have a very good topic today, the much read and the much searched, and researched literature. General anesthesia versus regional anesthesia for high risk geriatric cases. And we have two eminent speakers, both students from PGI. So let's see how they fight. Who's the first one? Ladies first, Kashish? Karan? Oh my God. Okay. So I invite Dr. Karan Singla, Assistant Professor, PGI Chandigarh. Karan has achieved over more than 30 publications in national and international journals, and he has been presenting his research at various conferences. He has also been to the World Congress of Anesthesiologists, Singapore, and he's been at the helm of affairs of organizing CMEs, STAC 2023. So, Karan, may we ask you to start your debate session? Where is he? Where is he? Hiding? I can't see him. So, the stage is yours, Karan.
हाँ जी.
Hello. Yeah. So good morning. I'm Dr. Karan Singla. I'm assistant professor in anesthesia at PGI Chandigarh. So the topic is a pro-con debate on general anesthesia versus regional anesthesia. So as the topic says, battle of the ages. So my introduction. So why do we call it battle of the ages? Because अगर हम देखें the research for spinal versus regional anesthesia started in 1975. And the other, this is 2021, so 50 years. अभी तक settle नहीं हुआ है कि which form of anesthesia is good in form of regional for an elderly. So again, absolutely correct that it is indeed a battle of the ages. Even now, अगर हम PubMed पे type करते हैं difference between regional anesthesia और elderly, there are at least 300 articles. उसमें भी अभी debate settle नहीं हुआ है कि which one is better. So why are we so concerned? Why so serious? This famous dialogue by the Joker. So main concern यही है कि the number of elderly people are on the rise. If you see that with increase in the age and with increase in better health facilities, the average or the mean patients or will get more of geriatric patients coming for surgery. So we need to see which one is, what form of anesthesia is better for the patient. So the anesthetic techniques, it basically depends on patient preference. If the patient says that I want general anesthetic or I want a regional anesthetic, then generally we can't help it. That's the patient's preference. Second is requirement of the surgical procedure. Third is anesthesiologist preference. So here's what we decide whether it is general anesthesia or you want regional anesthesia. Then coexisting diseases. If the patient is on blood thinners, patient is on anticoagulants, then that kind of precludes the use of regional anesthesia. Now, I come straightforward to the question. Now, why do I prefer a general anesthetic? I'm sorry for the font, I think it has changed, but the essence is that why do I prefer a general anesthetic? Now, the first foremost reason is better hemodynamic control. Whenever, since it's a CME of regional anesthesia for the elderly, so we are very concerned about most of our surgeries are orthopedic surgeries. So if we see what I've written is better hemodynamic control, BCIS, bone cement implantation syndrome, or massive blood loss. Now, if we see, there are at least now this tells the frequency of bone cement implantation syndrome. At least 1/3 of patients undergoing orthopedic surgeries or hip arthroplasties or knee arthroplasties will have some form of BCIS. Now imagine a patient being under spinal anesthesia and there is suddenly patient has bone cement implantation syndrome. The hemodynamics are all altered. Imagine blood pressure very low, tachycardia, and we are in a regional anesthetic. It becomes very difficult to get control of the airway. Second, blood loss. The second study tells that for major orthopedic surgery, there is a minimum of 2 g% decrease in hemoglobin pre and post surgery. So we expect around 600 ml. This is a median decrease. Surgeon surprises are always there. All due respect to the surgical team, they'll always say कि blood loss तो 200 ml हुआ है, जबकि there are buckets of blood on the floor. So we should always be ready for this. And I think general anesthesia is a better way of controlling the hemodynamics. Second is why I prefer better availability of short-acting anesthetics. So it was earlier that we had poorer knowledge about anesthetics, about how anesthetics behave in the elderly. Now we have better drugs. We know what the pharmacokinetics, pharmacodynamics are. If we know the pharmacodynamics, we can titrate our doses accordingly. All this is a chart which tells that about the reduction in doses of anesthetics, sevoflurane, desflurane. These are the drugs that we prefer in elderly operative patients. Now, availability of better monitoring techniques. We have been, with the advances in technology, we have better monitoring techniques like base monitoring, near-infrared spectrography, or cerebral oximetry, in which we can titrate our doses of anesthetics much better. Now, this is again a table which tells that if we what can we do to tailor our anesthetics, EEG based anesthetic dose titration, then use a cerebral oximetry. We have all these devices with us, so general anesthesia has become safer. Better airway equipment. So we are blessed with having video laryngoscopes, fiber optic laryngoscopes, supraglottic, better supraglottic airways. Now this is this article which tells about there's always a concern कि elderly में airway difficult होता है. अगर difficult होता है तो we have better equipment to manage those airways. So we should not be afraid कि हम regional anesthesia इसलिए देना चाहते हैं because airway is difficult. Why airway is difficult? Even in not so in very big institutes भी जरूरत नहीं है. Even in smaller institutes we have video laryngoscopes. We have started having made in India video laryngoscopes. ऐसा जरूरी नहीं है CMAX से cost 20 lakhs. We have Indian made which cost 4 or 5 lakhs. So we don't need a lot of money as well. So video laryngoscopes and FOBs, they are very commonly available in most of our institutes. So we should not be afraid of using the caring for the airway just as a so better to this is a very important concern for at least me, but easier to manage an anxious and agitated elderly. We all have elderlies at home. We know how difficult it is to manage them at home जब वो अपनी best हालत में होते हैं. They are so stubborn about their food, eat, drink. Imagine इस patient को अगर हमने regional anesthesia में करना हो. First of all, positioning becomes difficult. Then trying to convince them to get a regional anesthetic itself is very difficult. So easier to manage an anxious and agitated elderly. So this is a study which tells that approximately 33% of elderly they are anxious on the night prior to the surgery. So imagine again, as I say, even if we are successful in putting a regional anesthetic, we have a patient who is paralyzed below the in the lower limbs are paralyzed, but he's agitated. It becomes very difficult to manage. Then we give additional doses of anxiolytics, which it can itself can cause problems. Now these are again these are the general considerations for general anesthesia in the elderly. These are all basically things that we should take care when we are administering anesthetic, general anesthetic, pre-oxygenation, then reduction in the dose of anesthetics, then anticipating drug synergy. Hypotension being very common, peak effect of drugs being delayed, anticipating prolonged duration of neuromuscular blockers, and dosing of anticholinesterase inhibitors. If we have the knowledge about all these drugs, general anesthetic should not be a problem. Now, there are some myths about general anesthesia that most of us think. So myth one, the general anesthesia causes exaggerated hypotension. So these are two meta-analysis. One was in 2023, the other in Canadian Journal of Anesthesia, this in 2024. So they have done a meta-analysis of all the major studies done in the last 20 years. So they have concluded, these are landmark meta-analysis. So they have concluded that intraoperative hypotension in regional versus general anesthesia are indifferent. So this myth is busted. Second myth, GA causes increase in cardiovascular and cardiac complications. Again, the same meta-analysis. Again, they say that the incidence of cardiovascular and cardiac abnormalities or myocardial infarction are again similar between the two groups, between the regional anesthesia group and the spinal anesthesia group. So again, this reason again busted. GA causes increase in deep venous thrombosis or venous thromboembolism. The same meta-analysis, they conclude that there was no difference between the two groups. Neither the study in JC Journal of Clinical Medicine or the Canadian Journal of Anesthesia, they both say that there is no difference in postoperative venous thromboembolism. Again, busted. In fact, there is a study which says that spinal anesthesia has higher incidence of venous thromboembolism after total arthroplasty. This was the JPSVT cohort study done in Japan. Now, myth 4 is GA causes increased risk of post-operative pneumonia. Again, the same meta-analysis say that the difference in difference in pneumonia is approximately the same. Again, this myth is again busted. Now, GA causes increased risk of delirium. Delirium is a very important issue for a lot of anesthetists. They say that general anesthesia causes a lot of delirium. But then these are the two. This is one study which says that this Canadian journal, this is a meta-analysis which says that there's no difference in even in RCTs also there's no difference in post-operative delirium. Again, busted. So this is another trial which was done in 2022, which was published in JAMA, the Raga trial. They also said this is regional anesthesia versus general anesthesia. So again, the incidence of delirium between the two groups was comparable. This is even the American Society of Enhanced Recovery. They also say that there's insufficient evidence to recommend regional anesthesia as the primary anesthetic to reduce the incidence of post-operative delirium. So they have this society has recommended use of other cognition markers like returning of hearing aids, eyeglasses, sleep enhancement, pain management, medication review, early mobilization, reorientation, and minimizing of restraint use, optimum nutrition and hydration. So the society says that it is more imperative to deal with these cognition cues rather than the choice of anesthesia. Another myth is that GA causes increase in intraoperative blood loss. Again, this meta-analysis proves that the difference in blood loss between the two groups is minimal. Again, this myth is busted. Now, GA causes increased mortality. So again, the two meta-analysis say that the mortality rates between the two groups, GA versus RA, is again similar. So this myth is also busted. Now, this was a study done published in New England Journal of Medicine. So it said spinal anesthetic versus general anesthesia for the hip surgery. This was the REGAIN trial published in 2021. So they took around 1,600 patients. They also concluded that spinal anesthesia was not superior to general anesthesia for survival and ambulation. The average age that was included in these patients was 77 years in both the groups. The long-term mortality in the same REGAIN trial was followed up for 1 year. Again, the mortality rates were similar. So a little bit of criticism for the regional anesthesia. There is increased sensitivity to local anesthetics. There is increased duration of block, which prevents early mobilization. Then higher level of blocks, which are difficult to manage. And then there is higher degree of hypotension and bradycardia because of the physiological changes that occur, as has been explained previously by the previous speakers. Again, one important thing is difficulty in approaching the midline. We have calcified ligamentum flavum. We have seen our residents struggle for regional anesthetics. Positioning is difficult. So increased sensitivity to local anesthetics. So these are some causes which kind of precludes the use of, for me, the use of a spinal or regional anesthetic. So this is just a cartoon which says that regional anesthetic is more for selfies and put on WhatsApp and Facebook. Thank you.
I would like to invite now Dr. Kashish, who will be speaking for pro for regional anesthesia. Thank you, Dr. Karan. So Dr. Kashish, she is working in Postgraduate Institute of Medical Education and Research, Satellite Center, Sangrur. In her achievement, she has done fellowship in solid organ transplant anesthesia from PGI Chandigarh. She is a life member of Indian Society of Anesthesiology, Difficult Airway Society, Airway Management Foundation, Society of Trauma Anesthesia and Critical Care. And our areas of interest include transplant anesthesia, regional anesthesia, and resuscitation. Thank you, ma'am, for the kind introduction. So today I will be speaking in favor of today I will be speaking in favor of regional anesthesia. Why this debate matters? Elderly population requiring surgery is increasing along with the associated risk. Due to the comorbidities and frailty, they face higher perioperative complications. Both regional anesthesia and general anesthesia, they are options for common surgeries performed in the elderly population, such as knee and hip arthroplasty, hip fracture repair, lower extremity vascular surgery. So, this is a slide showing the advantages of the regional anesthesia over the general anesthesia. Regional anesthesia is associated with lesser pulmonary complication, has better pain control with lesser opioid use, promotes the early mobilization, decreases the deep vein thrombosis risk, and it improves the patient comfort by decreasing the post-op nausea vomiting risk, decreases the sore throat and delirium. It has better renal tolerance, has lesser impact on the immune system, and has lesser metabolic stress. This is an article published in JAMA Surgical in 2020 showing the association of increasing use of spinal anesthesia in hip fracture repair with treating an aging patient population. In this bar graph, you see the number of the spinal anesthesia cases are increasing over the years. In the patient, now coming to the pulmonary morbidity, the patient posted for the non-cardiac surgery, having aged less than 50 years, there is only 2% risk of developing the post-op pulmonary complication. But with advancing age, in the age group of 51 to 80 years, there is a risk of 5% complication. And as the patient is more than 80 years, the risk rises to 12.4% as the pulmonary reserves decrease with the aging lungs. Regional anesthesia is associated with lesser pulmonary complication as it avoids intubation, decreases the aspiration risk, decreases respiratory depression, and decreases the COPD exacerbation. With general anesthesia, there is a risk of 7.5% of post-op pulmonary complication in comparison to only 2% with regional anesthesia. This is an article published in Anesthesia Analgesia, Regional versus General Anesthesia in Surgical Patient with COPD. Does avoiding general anesthesia reduce the risk of post-op complications? In this, t- uh, t- uh, 2,644 patients were taken in the regional anesthesia group and the matched 2,644 patients in the in the general anesthesia groups were taken, and they have observed that the general anesthesia patient had higher incidence of post-op pneumonia, prolonged ventilator dependence, unplanned post-op intubation, and the uh, composite morbidity was 15.4% in the general group as compared to the regional anesthesia group. There is a decreased risk of deep vein thrombosis and pulmonary embolism, particularly after major surgeries like hip fracture repair with the regional anesthesia. And how did they do it? They do it by vasodilation and by increasing the blood flow in the lower limbs and by altering the viscosity and the coagulability of the blood. And these anticoagulation. This is an article published in 2024, Effects of General Anesthesia and the Spinal Anesthesia on the Post-op Rehabilitation in Older Adults After Lower Limb Surgery. In this, total 697 patients were taken, and the incidence of post-op complication, including the venous thromboembolism, was significantly lesser in the regional anesthesia group. Regional anesthesia group is associated with decreased incidence of DVT only in the absence of potent thromboprophylaxis. In the newer studies, once the modern thromboprophylaxis was used, the protective effect of regional anesthesia against thromboembolic events become less obvious, as shown in the recent Cochrane analysis. You can see in this forest plot graph, when no prophylaxis was given, then the risk ratio was 0.57%, favoring the regional anesthesia group. However, when the low molecular weight heparin prophylaxis was started, this risk ratio rises to 0.98, having no favorable effect on the regional anesthesia.
This is an article published in BMJ Open in 2019, and this article shows there is a significant difference in the development of the pulmonary embolism in the general anesthesia group when they are compared with the regional anesthesia. Now coming to the cardiovascular stability, regional anesthesia group is associated with stable blood pressure and heart rate. There are less chances of intraoperative hypotension and cardiac stress, and there is a decreased incidence of supraventricular arrhythmias and atrial fibrillation. However, with general anesthesia, there is an increased risk of hypotension and tachycardia and cardiac complication due to less sensitive baroreceptor reflex and increased vascular rigidity. This is an article published in 2024 Canadian Journal of Anesthesiology, and in this article, total 9 studies were taken, including 4 RCTs and 5 observational studies, and this has shown the incidence of intraoperative hypotension was lower in patients who received regional anesthesia in comparison to the general anesthesia. There is another meta-analysis published in 2023 comparing the effect of spinal and general anesthesia for hip fracture surgery in older patients. And in this, 9 studies were taken having 3,000 participants, and there was lower risk of intraoperative hypotension in the spinal anesthesia group in comparison to the GA. In addition to it, spinal anesthesia patient required significantly lesser amount of the ephedrine. This is a randomized controlled trial published in JAMA in 2021, RAGA trial. In this, they have observed the intraoperative hypotension as a secondary outcome. And in this, there was 2.5-fold increase in intraoperative hypotension in the GA group when it was compared with the regional anesthesia group. This is another randomized control trial published in 2022 comparing the hypobaric unilateral spinal anesthesia versus general anesthesia for hip fracture surgery in the elderly. In this, total 154 patients were taken, and the hypobaric spinal anesthesia group, it was having lesser hypotension in comparison to the GA group. This is a Cochrane analysis, and this analysis has observed that the risk of operative hypotension was lower with the low dose unilateral neuraxial blockade. Now coming to the analgesia, regional anesthesia is always is associated with the superior post-op analgesia. There are decreased pain scores 1 to 6 hours post-operatively in various surgeries, and it is associated with decreased post-operative analgesic and opioid consumption. And these benefits are more pronounced in elderly due to decreased pain-related complications like delirium, respiratory depression, adverse pharmacological effects, and prolonged hospital stays. This is a study published in Cochrane, Epidural Analgesia for Pain Relief Following the Hip or Knee Replacement. In this, 11 of the 13 studies evaluated post-operative pain relief comprising 236 participants. At rest, epidural analgesia may be superior to systemic analgesia in the early 4 to 6 hours post-operatively based on the VAS scores. And with ambulation also, this suggests epidural analgesia may be superior to the systemic analgesia. We all know both the general anesthesia and spinal anesthesia, they are associated with PUNV, but the general anesthesia is 9 times more associated with the PUNV. And this study has shown this outcome. In this, the patient undergoing general anesthesia were more likely to experience PUNV as compared to the regional anesthesia. Then the stress response. Surgical stress leads to raised cortisol and catecholamine levels, leading to increased risk of hypertension, hyperglycemia, and increased myocardial oxygen demand. Studies have shown that regional anesthesia blunts some metabolic and endocrine response compared to the general anesthesia. And the elderly patient, they are less able to cope with the physiological stress of surgery, making this benefit of regional anesthesia particularly valuable. Coming to the gastrointestinal recovery, regional anesthesia is associated with faster recovery of GI function post surgery, and this is beneficial in elderly where delayed return of bowel function leads to complications like ileus and prolonged hospital stays. Meta-analysis has found that regional anesthesia, particularly epidural, led to faster recovery of GI function, reduced time to oral nutrition, and earlier bowel movements. Surgical site infection post arthroplasty leads to prolonged hospitalization, readmission, and reoperations. Regional anesthesia reduces perioperative infections by decreasing the inflammatory and neuroendocrine stress response, by increasing the tissue oxygenation through vasodilation, and by providing effective post-op pain relief by decreasing the vasoconstriction and improving the peripheral vascular perfusion. This is a study published in the International Wound Journal, Impact of Spinal Anesthesia versus General Anesthesia on the Incidence of Surgical Site Infections After Knee or Hip Arthroplasty. In this, total 15 articles were taken, and this has showed that the spinal anesthesia showed 23% lower likelihood of developing SSIs post-operatively in comparison to the GA. Regional anesthesia offers better renal tolerance as there is reduced renal handling of the systemic medication in comparison to the general anesthesia where systemic drugs can worsen the renal function, increase the AKI risk as elderly patients have reduced GFR and renal reserve. This is a study published in British Journal of Anesthesia in 2022. In this, total 15 RCTs were taken between 2003 to 2022, and this has shown that the spinal anesthesia reduced the risk of AKI compared with the GA. Studies have shown that the regional anesthesia leads to lesser blood loss, and the mechanism is it blocks the alpha and beta adrenergic receptors, lowers the heart rate and BP, leading to controlled BP, leading to lesser blood loss. This is a study published in World Journal of Surgery in 2023, and this has showed that there is a significant difference in the intraoperative blood loss between the two groups. Now we will be discussing about delirium. Regional anesthesia has lesser impact on the central nervous system and it also has decreased sedation requirements, which results in lesser incidence of post-op delirium and cognitive decline in comparison to the general anesthesia, which is associated with longer recovery times, higher opioid use for pain management, and use of drugs affecting the CNS, leading to increased chances of post-operative delirium. These are the two studies which favors the regional anesthesia over the general anesthesia. One is published in the BMJ Open in 2019, and it has a sample size of 96,289, which shows a lower incidence of delirium in the regional anesthesia group. And the another study published in 2019 in the JAMA journal, and this study also shows a lower incidence of delirium in the regional anesthesia group, and it also has shown that with every 30-minute increase in the duration is associated with 6% increase of delirium. This study has already been discussed by Dr. Karan, that is the REGAIN trial, which was published in NEHM, and this trial has shown that there is no difference between the two groups with regard to the delirium. But if you look at the methodology, the patients in the regional anesthesia group, they were given the sedation, and that too 23% received ketamine and 44% received midazolam, which have strong association with the delirium. And the American Society for Enhanced Recovery has clearly stated that these medications, they should be avoided so to prevent the post-operative delirium in older high-risk surgical patients. This is another study, that is the RAGA trial, which was published in JAMA in 2021. And this trial also said that there is no the two groups are comparable with regard to the delirium. But if you look at the number of the patient which they have taken in the GA group, the GA group had also received epidural spinal anesthesia. 2.9% of the patient they had received general anesthesia along with the CSC. 3.5% patient they have received epidural anesthesia with the general anesthesia, and 21% patient has received the nerve block along with the general anesthesia, and 0.7% patient had received general anesthesia and spinal anesthesia. Along with it, this study had an overall low incidence of delirium, that is only 5.1 to 6.2% in comparison to the 11.1 to 23.3%, making the generalizability and potential quality of the delirium detected in the sample difficult to
Dr.
interpret.
Kashish, please conclude.
Ma'am, only 2 to 3 slides are left. Uh, and you can see in this graph that the incidence of hyperactive delirium and the mixed motor agitation, they are reduced in the regional anesthesia group in comparison to the GA group. Only the hypoactive delirium is increased in the regional anesthesia group, and hypoactive delirium as such is very difficult to diagnose in the post-op patients. Now coming to the mortality, majority of the studies show no significant difference between the two groups, but few studies shows decreased 30-day mortality with the regional anesthesia, but the effect did not persist beyond the 3 months. These two studies have shown that the regional anesthesia has had a lower 30-day mortality in comparison to the GA. But this study, that is the REGAIN trial, shows no significant difference in 30-day mortality or 60-day ambulation. But I want to take into your account that the anesthesia, that these outcomes, they may not accurately reflect the anesthesia impact, because these are influenced by many external factors such as the patient comorbidities, post-op care and rehabilitation services, which are beyond the anesthesia choice. Regional anesthesia leads to shorter hospital stay, lesser ICU admission, and cost, as shown in these two studies. Now, my take-home message is regional anesthesia offers better respiratory stability, cognitive protection, and faster recovery with fewer opioid and infection risk. Thank you.
Thank you, Dr. Kashish. Now we will give 2 minutes to Karan to rebuttal regarding post-op AKI, post-operative infection, and PONV. You have not mentioned that. You want to defend?
So regarding AKI, the meta-analysis that I showed, the one which is published in 2024, the Canadian Journal of Anesthesia, they have mentioned about AKI as well. Again, there were no differences in the incidence of acute kidney injury between the RA group and the in the regional group and the spinal group, regional group and the general anesthesia group. Further, AKI, it depends, depending only on the type of anesthesia is, again, little, it's a sticky ground ki only the form of anesthesia caused AKI. Regarding PONV, we have multimodal, we have so many medications for PONV that we can use, except for maybe not using metoclopramide in elderly, ondansetron, Rantide. We have good antiemetics which can be used. Again, as Dr. Kashish pointed out, that it's increased incidence. That is maybe because of use of opioids. We have opioid-free anesthesia, opioid-free general anesthesia can be used for general anesthesia. So that does not preclude the use of general anesthesia. The advantages of general anesthesia, as I pointed out, better hemodynamic control, it's better better with an anxious and uncooperative patient, putting the patient positioning difficulties with the regional anesthesia. I think they kind of outweigh the use of general anesthesia.
So, raise your hands for Karan. How many in the house is convinced with Dr. Karan? Who all go with Dr. Karan? GA is preferred over regional anesthesia for hip fractures, especially. No? Everybody's with Kashish? Many factors. Dr. Ira, please.
Why this happens with spinal and why this happens with general anesthesia? Is there any explanation? It's just association that in patient may not be single general or spine. But I think I can manage any patient with either technique depending upon the patient's comorbidities. What are the patient's risk factors? What is the surgery being performed? What is the duration of the surgery? If all these parameters are taken care of, I think we can titrate our anesthesia with the n number of drugs and the equipment available, either way to the same participant.
The fallacy of most of the RCTs that have been done is that first is randomization. Even if the patient has a better outcome or maybe more, appear better with general anesthetic, he was randomized to a regional anesthetic. So, randomization में ही अगर patient को comorbidities, multiple comorbidities हैं, but he got randomized to a general anesthesia group. So automatically उसकी mortality change हो जाएगा. In fact, so randomization in these patients itself becomes in these studies is it is biased because we are not taking into consideration patient का comorbidities. We are taking हम randomization अपने on the basis random कर रहे हैं हम. We are not taking into consideration patient का क्या preference है. So that's why I'm saying that फिर वहाँ पर patient का preference या patient की comorbidities का I'm talking about the fallacies of these trials, as you said that these trials don't mention this. So
Even the retrospective data previously used to show that less patients have received general anesthesia. We all know that spinal anesthesia is preferred because it's the simplest and the safest, because you need just one needle and that's it. But as you have said, if you know how to correctly manage either of the techniques, given today's era, both are equal. So the only thing is we should not take spinal lightly. And if your patient is having comorbidities, you should monitor the patient in similar aspect as you would for a general anesthetic. And then you have to look at what complications can happen with each of the techniques. Like in our times, people would say, like, if you put a tube, then patient is half resuscitated. Especially if your patient is in the lateral position and the patient is undergoing bone cement. And at that point of time, if your patient has not been resuscitated adequately because you have got that concept in your mind that it was just a simple spinal, I don't need to monitor anymore. Those are the things which also contribute to mortality and morbidity. If you are vigilant and you have categorized your patient and according to that you have chosen your anesthetic management, I think both are giving equal results. That is why the debate still goes on, because this group is difficult to randomize, and then subgroup analysis and 30-day mortality is not it. Sometimes you have to go even beyond this. And I think if I'm not mistaken, Tanveer, you have that 1 year data of that femoral proximal from femoral fractures. So in that, did we find any benefit of doing spinal in our own setup? This is all Western literature. In our own setup, we did not have any, there was no difference in 1 year mortality if you do either of the techniques. So I think the word today is that monitor your patients diligently, whatever technique you are doing. And people are even talking about, he talked about difficult spinals. So people are even talking about ditching your 27 gauge for a 22 gauge in case you are finding it difficult. So I think we need to improvise our technique in both the aspects. It's Vignesh.
The other thing is, it's not just simple as spinal versus GA. I think we can do what we want to, do it well, but I think peripheral nerve block should be incorporated into either of the plan. Just because a patient is having a spinal does not mean that he cannot receive a block for the surgery. So the most of the practice guidelines says that whether they get a spinal or a general anesthetic, all of them get a fascia iliaca nerve block intraoperatively, and which extends into the postoperative period. So these the Raga regain trials and all that, which showed compared regional versus general anesthesia, it was the peripheral nerve block plan was not standardized in all of the patients. So not all of them received a block, and that could have had implications over.
Any comparison in rebound pain?
In sorry?
Rebound pain.
Rebound.
GA versus regional. So next time we can discuss that. Rebound pain. questions? Can we ask any question in this?
I think we should close the session because this is very well researched topic, and we congratulate both the speakers for defending their this thing. I don't think he is a proponent of GA; he is defending a topic. So we should give a bit round of applause.
I thank the esteemed faculty for their enlightening presentation, enhancing the depth and value of our conference discussion. I invite Dr. Ashwini to felicitate Dr. Kajal Jain. I invite Dr. Bharti to felicitate Dr. Karan Singla and Dr. Kashish Garg. I now invite Dr. Ritu Gupta on stage.
Okay, we now come to the end of our talks and presentations. But before we move on to the most awaited part of our conference, that is hands-on workshops, we are delighted to announce the winners of e-paper and e-poster presentation. I would like to thank Dr. Sneh, Additional Director, Department of Anaesthesia, Fortis Hospital, Mohali, Dr. Sunny Rupal, Associate Director, Livasa Hospital, Mohali, and Dr. Vinita Venkateshwaran, Ex-Assistant Professor, Department of Anaesthesia, AIMS, Mohali, for taking out their precious time and graciously evaluating the presentations. To declare the prizes, the first prize for the e-poster goes to Dr. Sukhpreet, GMCH 32. I request Dr. Sneh to hand over the certificate and cash prize. Sukh Puneet. Sorry. Hmm. The second prize goes to Dr. Pooja, GMCH 32 Chandigarh. I request Dr. Sunny to please kindly do the felicitation. Okay, the first prize for the e-paper presentation goes to Dr. Amit Panwar, PGIM at Chandigarh. I request Dr. Vinita to kindly do the honors. The second prize goes to Dr. Khalid Mohammed. I request Dr. Pooja to kindly felicitate him.
I also request Dr. Ritu to felicitate Dr. Sneh, Dr. Sunny, and Dr. Vinita.
So moving on now to the workshop session, we have a group of talented and eminent faculty to share their expertise on upper limb blocks, lower limb blocks, chest wall blocks, truncal blocks, sonoanatomy of spine, and transthoracic echocardiography. I would like to take at this opportunity to quickly introduce our workshop faculty coordinated by Dr. Sanjeev Palta, a professor in HOD GMCH Chandigarh. We would also like to welcome Dr. Vikas Saini, Professor, Department of Anesthesia, PGI, Chandigarh, Dr. Richa Saroha, Professor in Department of Anesthesia, GMCH, Chandigarh. It is a pleasure to invite Dr. Sapna Bansal, Professor in HOD, Department of Anesthesia, Malana Medical College, Ambala, Dr. Tanveer Samra, Additional Professor, PGI, Chandigarh, and Dr. Harsimran Walia, Associate Professor, Department of Anesthesia at Homi Bhabha Institute, Mullapur. We would like to extend a warm welcome to Dr. Deepika, Assistant Professor, GMCH Chandigarh, Dr. Ira Dhawan and Dr. Vignesh, Assistant Professor, PGI Chandigarh, Dr. Komal Lali, Assistant Professor, Guru Gobind Singh Medical College, Faridkot, Dr. Varun Mahajan and Dr. Ashish Aditya, Assistant Professor, PGI, along with Dr. Bismanjeet, Assistant Professor, PILDS Mohali, and Dr. Ashwini, Assistant Professor at AIMS Mohali. The workshop will be conducted in the MU at the 4th floor, where we will have 6 stations, and all the delegates have their stations written at the back of the batches, and the delegates will be rotated among the station every 30 minutes. So now we request you all to proceed to our workshop venue on the 4th floor. We'll be going. There is a lift. We will guide you there. Thank you.